Welcome to the Thinking Practitioner podcast.
A podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Luchau.
Welcome to the Thinking Practitioner.
The Thinking Practitioner podcast is supported by ABNP, Associated Bodywork and Massage Professionals. ABNP membership gives professional practitioners like you a package including individual liability insurance, free continuing education, quick reference apps, online scheduling, and payments with Pocket Suite, and much more. ABNP CE courses, podcast, and Massage and Bodywork magazine always feature expert voices and new perspectives in the profession, including Whitney Lowe, my co-host, and articles by myself, Till. Thinking Practitioner listeners can save on joining ABNP at abnp.com/thinking and mention to them that you heard about them on our show. That always helps support the show as well. How are you doing, Whitney?
I'm doing fine today. How are you doing, sir?
Fine, thank you.
All right. We have a wonderful guest joining us today on our discussion. We would like to welcome Mark Olson to the Thinking Practitioner. Mark holds a master's degree in education and a PhD in neuroscience from the University of Illinois, specializing in cognitive and behavioral neuropsychology and neuroanatomy. His research focused on memory, attention, and movements and aesthetic preferences. Dr. Olson is a published author with recent articles on chronic pain and trauma-informed care. I would also briefly mention that we did a whole episode on one of Mark's articles quite a while back, so we're looking to dive into some of that stuff again. So Mark, welcome to the Thinking Practitioner. Great to have you here.
Yeah, great to be here. Thanks.
Yeah. Anything you want to add in talking a little bit about your background in relation to neuroscience and massage before we jump into our discussions, things we didn't cover there?
Well, you covered the critical details, basics. I guess I would say that for my PhD research, I studied memory of complex, ordinary scenes like we see every day, and I did it with implicit variables. So, as you know, instead of asking a person, "Have you seen this before?" That's an explicit variable. I used implicit, or you might say somatic variables. We looked at your eye movement patterns. So, looking at implicit variables to kind of see under the hood is one of the things that seems very relevant to massage therapy, because there's a lot of things going on that aren't in conscious awareness. So I think that's good to mention that implicit variables go back a while.
Yeah, tell us a little bit about how you got involved in this field.
I'm curious to hear that as well.
In massage therapy, yeah. Well, I was not thinking about massage therapy at all when I was in studying neuroscience. I studied neuroscience because I just wanted to understand what makes us tick, understand behavior, thought, feelings. And I thought, well, massage would be kind of a fun thing to learn just for kicks and giggles. Mm-hmm. And little did I know that it was much more than fun kicks and giggles. So, I took the class in it after I got my PhD, and I realized, I really like this. And there's lots of really interesting things going on here that are a lot more interesting than I would have expected.
Mm-hmm. Great. Well, you've certainly contributed some wonderful things to us. And we want to dive in today to some of the discussions about the relationship between neuroscience and massage. And I was wondering maybe if we could just kind of start with giving us just kind of an overall review concept of the basic outline of nerve processing, such as the input and output pathways and motor versus sensory activity. And we'll kind of take that as a starting point for some of our other discussions there.
Yeah, great. I think that would be really good to kind of establish a baseline of terms here, because there's so many terms.
Yeah.
The input, the output, the sensory, the motor, the afferent, the efferent, the top down, the bottom up, and just to get them all to make sense is a task in and of itself. I think we're used to thinking in terms of like a stimulus and a response and an input and an output. And I think most of us have learned this idea that we have sensation from our eyes or from our skin, and then there's a signal that goes up to the brain, and then we see things or then we feel things. But that is a far oversimplified version of how things actually work. And with all the sensory systems, including pain, including normal touch, that there's a lot of what we call top-down influence. So you have the signal going up like you would imagine, but there's also signals going down. So, probably all of us in massage schools learned that you have afferent signals, which are sensory signals going up, and we have efferent or motor signals going down, but we could also say we have efferent, but we usually use the word descending signals going down that influence the whole process of the sensation or the perception. And what I mean by that is I don't mean that we get the incoming signal and then we think about it or compare it to a memory and then we act after that. That's a different thing. That would be a stimulus response model. What I mean is that the sending signals are influencing the ascending signals so that our experience, the actual experience of what we taste or what we see or what we feel is influenced by what we already know ahead of time. So we have all this prior knowledge from decades of living that shape our perceptions and shape the incoming, the raw data coming up. So we call those top-down influences as opposed to the bottom-up raw data influences.
Mhm.
So the descending modulation that I've written about, that's an example of a top-down influence on sensory processing.
And this, of course, is, from what I understand, influenced by all kinds of things of previous experiences, illnesses, neural problems, and things like that can make that descending activity either increased or decreased. Is that correct?
Absolutely.
Yeah.
Sure. I mean, if you've had terrible experiences with doctors or great experiences with doctors or massage therapists or whoever, there's conditioning responses there that are going to influence you. Whether, I mean, I say conditioning, meaning that you may not even be aware of your preferences or opinions about those individuals and those kinds of treatments. And also, you could have a conscious expectation. So those would be two different kinds of influences, positive or negative, that could
Hmm.
come to play.
Yeah.
Other influences, top down, besides expectations?
Yeah, absolutely. So the expectations would be if somebody said, "Hey, I heard that Till was a great body worker, so this is gonna be great." That's my expectation, right? But I could have these conditioned responses to, the people with beards, or the colors of the wall, or probably not colors of the wall, but other uh, you know, uh, aspects of the environment that could be influencing. There's also with that particular person or with the setting in general. So any number of things are influencing all the time that we couldn't possibly know about or control.
It's fascinating to me that those conditioned responses, especially, are below the level of our cognition or thinking. It's not even I'm thinking, oh, somebody's a great practitioner. It's deeper than that, or it's thought to
Mhm.
be just the way that we're responding to things that's we've been
Yeah.
conditioned into our nervous system.
Yeah. I mean, so much of life is that way. I mean, we think that we have these conscious thoughts and we make these conscious choices, but neuroscience keeps on showing us that that's just not the case, that the show is really being run by a lot of subconscious influences that we don't really know. I mean, it's kind of Freudian, but it's also like the neuroscience is backing up those ideas.
And this stuff is obviously happening very, very fast in
Hmm.
terms of the time it takes for those influences to make changes in descending activity would seem like incredibly fast.
Absolutely. Yeah, I mean, I can't quote you the different studies, but if you do EEG studies, we have things called P300s and N200s and other markers that show up in relation to different kinds of stimuli, 200 milliseconds or 300 milliseconds before you have the conscious awareness of the stimulus.
Hmm. Yeah. So this is sort of explanations of that descending activity, but there is also you've talked about before ascending inhibition of pain as well, correct?
Hmm.
Yeah. So
Yeah.
how does that work?
Yeah. So the ascending inhibition, which is often referred to as gate control theory,
Hmm.
that's the idea that you have myelinated signals that make it to the spinal cord first, and then they kind of turn around and look at the slow, unmyelinated signals coming up and say, "Hey, we're not going to let you through. You shall not pass," or something like
Hmm.
that. So that's an ascending. We do this all the time. If you stub your toe, your hands immediately go to your toe and they surround your toe, and that um, dampens that ascending signal because of uh, the other touch information around it is influencing it. There's other aspects to that besides ascending inhibition, but that would be it's two ascending signals that are going at different speeds, and one is inhibiting the other. And then descending inhibition is it requires the brain to get involved. So you have signals coming down from the brain and inhibiting signals at the spinal cord. In both cases, you have the inhibition happening at the dorsal horn of the spinal cord. So whether the signal's coming up from your toe or coming down from the brain, there's an inhibition that happens right there at the dorsal horn, which influences whether that signal is going to keep going or to what, like it's going to be dampened or if it's going to be accentuated on the way up to the brain.
Let's go really practical if we could about that, because these are really, you've explained them really clearly. They're concepts that have been bantied about in our conversations for a while. What's an example in an actual tabletop situation of descending modulation, say?
Mhm. Yeah, well, somebody, so the therapist makes a comment that could be either, say, comforting or disturbing, um, but just because of their own relational skills. And obviously, if it's comforting, they say something that feels like, oh, this person cares, they're with me right here. Um, they're going to have more implicit safety, and that's going to influence a descending modulation signal. That will
Which
increase
basically makes it hurt less.
hurt less, right?
Great.
Somebody holds your hand when you're sick, that feels better. Uh, but somebody says something that says,
Asks
"Gosh, you're
you ask you about politics.
yeah," ask you about
Right.
politics, or
Yeah.
or gosh, your shoulders, seems like it's really messed up here.
Yeah.
It changes your idea about yourself, and or says something that doesn't make you feel safe with that person. That changes the implicit safety levels, which is going to change the descending modulation.
Changes the descending modulation. In other words, it hurts more, perhaps, or there's
It
more protective responses in general.
certainly more protective responses because it's the spinal cord which is going to be influencing those muscular outputs. So you could tense up, from that as opposed to allow more relaxation. But yeah, you could have more pain, at least in theory. Hmm.
Okay, I'm trying to go really practical, but I can't help this little divergence. Is there such a thing as descending facilitation, or is it all
Yes,
inhibition? Okay, so it
there's
can
this in.
amplify or it can dampen. Yeah.
Yeah.
Okay, so now a really practical example of the bottom up, the gate control, say. How does that show up on our table?
Well, I think that's probably just happening all the time. If whatever, so we have low levels of nociception happening all over the place, and um, some of it we're aware of, we become aware of as pain, and some of it we don't. So as we're being touched, that's providing tactile input, which is going to be potentially uh, kicking in the ascending inhibition. So during a session, you have ascending inhibition potentially happening all the time, all over the place.
Let me see if I can say that in ordinary English. So when we're touching, you said there's tactile stimulation. There's a touch sensation. The
Yeah,
sensation of the touch itself might uh, modulate or turn down the pain sensation,
yeah,
pain signal,
mhm,
say.
yeah, mhm,
Okay.
And since my understanding too that a lot of the benefits of the ascending modulation have to do with proprioceptive sensations that are traveling faster than the nociceptive sensations. Is that correct?
Proprioceptive is fast, yes.
Yeah. So would you then say also that, for example, movement incorporated with massage might even provide more potential ascending inhibition than just massage alone because there's increased proprioception from the movement activities?
Um, it Might. However, I can't speak to that like with absolute certainty
Yeah.
if that's been determined or not.
Hmm.
You're thinking, Whitney, you're thinking just more signal has more effect, or other means of generating that proprioceptive
Yeah,
signal.
just curious, like if more of that signal might overwhelm more of the nociceptive signals, based on sort of the gate concepts during the ascending activities there. Yeah.
I mean, just in general, just the way the nervous system tends to work, I would expect something like that to be the case.
Yeah,
But I don't have like a paper or a study in mind that, or anything that tells me that that is the case.
Well, I
sure.
don't I don't have a study or paper in mind either, but I'm thinking about the well-known phenomenon of night pain when there's not movement, that people's, especially neuropathic pain, will get more acute, get more intense without the movement that happens during the day, and they start moving again, and just perhaps the nervous system activity proportionally dampens down the experience of that
Yeah,
neuropathic
yeah,
pain.
absolutely, absolutely. I think that makes a lot of sense. But then there's also the fact that you have more inflammation at night too, so that's
Uh-huh.
confounding there. But
Right.
yeah,
Yeah, there you go. Yep.
but I think both are probably happening.
Yeah, that brings up another interesting thing I was thinking about because I know a lot of the studies about motor learning that I've looked into have advocated and said that basically thinking about a particular movement can be very substantial in training that movement,
Hmm.
in addition to doing the actual physical movement. And I wonder, like, maybe you know something about this in terms of our dreams. When we are active in our dreams and doing something, might that play a role in night pain because we're activating those motor pathways that are associated with pain in the waking hours?
Hmm. Yeah. Okay. Well, I mean, the practice of a motor skill in your mind is activating those same pathways as would be if you're actually doing it. The only thing that's different is you don't have that last efferent signal out to the muscles. Um, but that's all happening in the brain. So if there is an inhibitory effect there on pain, it's not going to be at the spinal cord level because it's not happening at the spinal cord
Yeah.
in the but dreams are actually practicing things that we've learned. We've seen that in rat studies quite a bit.
Yeah. Interesting.
We've seen rats practicing things they've learned.
If you give them a task and you look at like which neurons are activated during that task, you can see that while they're sleeping, that the same neurons are activated. It's as if they're because there's an
Doing it.
integration that goes on during sleep and dreams. Um, and if you disrupt that process, then they don't learn it as well. They won't for the next day.
Cool.
Yeah, fascinating. I know there's been a lot of discussion of pain being more about perceived danger than sometimes tissue injury in a lot of instances. And how can massage and manual therapists integrate that concept into their practice more effectively?
Yeah, well, I think it's very natural to think about pain in terms of injury because that's how we grew up. Learning about pain is by injuring ourselves, but then we ended up with adults, as adults with a chronic pain, and kind of transferred that idea over.
Hmm.
When actually the chronic pain doesn't, work in that same way. It doesn't have to require nociceptive input, at the skin or at the tissue level. Um, so it's important to let go of that idea that we have that, oh, that means that there's something out here in the tissues. Um, you can actually ask me that question again because I'm forgetting what you just asked
Yeah,
me.
just curious, like this whole idea of pain, pain perception or pain being not about or being about perceived danger in relation to tissue injury, and like how can we use that clinically, or use that information like, and this sort of like leads into, let me sort of ask another question on top of that because I'm curious to hear your take on this. I know with sort of the popularity in the recent decade or so of the pain science movement, a lot of emphasis on learning more about pain. There's been a greater effort for us to encourage teaching our clients or patients about what's the nature of that pain problem. But I think that's also opened up another group of problems of recognizing that it's really difficult to do that for
Mhm.
people who have no background in this, for them to understand the complexities of neuroscience in just a few, short sentences or short conversation. Does that
Hmm.
whole thing about, this whole idea like, well, your tissues aren't really injured. This is just a perception problem of your brain. Does that create more problems sometimes than it solves?
It definitely creates new challenges, right? Because people have the ideas that they have, and they're very ingrained, and it does take quite a bit to re-educate fully. I mean, I teach classes on this, and we take many hours to do that. And so at the end of the class, it's like, okay, now what? Because now we have to figure out how to convey this in 2 minutes. So that is a
Yeah.
problem. I mean, I don't think that we need to educate our clients to the same extent.
Yeah.
And it's not like we have to have a whole neuroscience lesson. But I think if they have limiting ideas, if in which a lot of clients do, that they think that their back pain is associated with what they see in that X-ray, I think it's really helpful for them to realize that a lot of the things people see in X-rays are things that happen for people who don't have pain.
Hmm.
So you can't. It's very easy to just see A and B and put them together and assume that they're causally related, but I think it's good to drop the idea into one's mind that, it's possible that that pain that you're having, isn't because of this. And so it doesn't feel like a prison sentence, because if,
Hmm.
if you think that it's a tissue related phenomenon and that it's something that you really can't change, then, there's a little bit of descending facilitation right there. Like, oh, guess it's hopeless.
Hmm.
So, we don't want to instill false hope, but I think we should remove false despair and give people hope where it is, where it's possible.
Love
Yeah.
it. That's nice. And there's at least two avenues there. One is the possibilities we might open up for our clients in our conversations or information we might share, the education part. But the other one that's even lower hanging fruit is this the way we're thinking about it as we're touching it.
Mhm.
It's a big shift sometimes to think that I'm actually affecting the brain with my touch and that that's going to have an impact on someone's experience, no matter what their scans say or what they think of their scans or their ideas about it. But
Mhm.
this to actually give someone an experience on the table with my touch is itself a potent lever that I can use.
Yeah. Yeah,
Hmm.
absolutely. I think that there's this focus generally to think that we're working with tissues. It's usually defined as soft tissue manipulation, right? Um, and we're thinking, oh, it's muscles, it's fascia, and that kind of thing. And I think it would be better if we thought of ourselves not as soft tissue manipulators, but as interoceptive modulators. We're changing.
Interoceptive modulators, great.
Mhm.
I actually think of myself as a soft tissue manipulator. The brain is pretty soft tissue,
Yeah.
but that's my target anymore.
And
The
I
Hmm.
brain.
to put a plug in this till you said something in one of our very early podcasts when we first got started, and I have quoted you in almost every workshop that I've taught since then of saying that the perhaps most important tissue that we work on is the one between the ears. So
Wow.
yeah,
Hmm. I
I
like
think
that.
that
It is
yeah.
very soft.
Right. Yeah. And obviously quite malleable in various different
Hmm.
ways. Yeah. So yeah. So Mark, taking this a step farther, talk a little bit about environmental and social cues that play a role in pain perception and how some, maybe therapists can optimize these things. I know we've talked a little bit about this, but you know, people often ask, like, well, what are really some of the other benefits of things that we can do? And I like to encourage people to recognize that there's some real value in the things like the soft lighting, the quiet music, the smells, all the things that come along with what you do with your hands as
Hmm.
part of the total package. Is that something that's sort of grounded in neuroscience as well?
Yeah, absolutely. And I think a lot of times people want to make this distinction between spa work and quote therapeutic work.
Hmm.
And because the spa work would probably be more about the soft lighting and et cetera, that kind of thing.
Yeah.
But I think if you want to work with pain, you need to dial that in really
Hmm.
well so that you create an environment that the senses are naturally going to generate more implicit safety around.
Yeah.
So and that's especially true for individuals with trauma or shock trauma. Anything you can do to bring the system into a more regulated state is going to make your work easier. You're gonna get to the places you want to go to quicker
Hmm.
if by
Or
using those other modalities
or grief, my
or
favorite topic
grief.
lately.
Hmm.
I mean, I had an amazing session with a practitioner who orchestrated this whole sensory experience with the uh, essential oils she was bringing in, the music, the lighting, and her touch was fantastic too. But that whole sensory package, I could just feel it changing in my state and providing me a place to let go into that no amount of skilled touch by itself would have done without those other factors there.
Yeah, absolutely. Yeah, and with the social cues, I mean that's we're social creatures, so we respond to social cues so strongly. And I mean I think it's fair to assume that everybody who goes into bodywork is a caring, loving person who wants
Somewhere in
to
there.
somewhere in
Yeah,
there.
right.
But we don't all do it to the same level of skill. And
Hmm.
so, to whatever extent we can improve our relational skills, because people say things on the table that require a response of some kind, whether they say they're sharing something that's potent for them or emotions just arise. And there's a thousand different ways we can respond at any moment, and some of them are more skillful than others. So, those are going to go a long way for creating a sense of implicit safety.
So I'm curious to know your thoughts on this too, with this exploration into recognizing the the incredible power and influence that the brain and the nervous system have on our experiences of pain. How relevant or important do you think it is in terms of somebody comes in and says, for example, my neck hurts, my shoulder hurts, or whatever? How relevant and important is it to try to identify if there is a nociceptive cause to that, or if this is something that is more general of a pain complaint in there? Is that therapeutically beneficial, do you think?
That's a great question.
Mhm.
Um, well, I think if you can determine what the source is, that would be great, but many times you're not going to be able to.
Wait a
Hmm.
minute.
You know,
Wait a minute. If you can determine what the source is, meaning like a nociceptive tissue located pain driver. Is that what you
yeah,
mean?
is it nociceptive?
I see.
Yeah.
Hmm. But
Source is complicated, but yeah, I get what
source
you
is
mean. Yeah.
complicated.
Yeah.
Right. So if we could see, with like a God's eye vision and know, is this inflammation? Is this an impingement situation? Are we talking about sensitization? I mean, that'd be useful
Yeah.
to have that, but can we acquire it? I mean, we can make some educated guesses based on, various variables, but ultimately, um, we're still gonna provide quality touch and care, and that's going to go a long way in all those situations. So I don't think we have to know in order to be helpful, because I mean I think we are helpful, almost all the time without actually knowing.
Hmm.
But at the same time, I think sometimes we apply false ideas about what's happening. Like if I think, oh, this is a problem because your posture, and that's actually not the case. But I still gave a good session with that false belief, and you came out of it feeling better.
Yeah.
But if I had a better idea about how things were actually working, I'd probably be able to, uh, you know, fine tune that help
Hmm.
more.
So when you have, for example, because I see this situation a fair amount too, let's say a client who is absolutely convinced that they have fill in the blank, whatever it is, that they have plantar fasciitis or they have, something that's causing their pain. But you might not necessarily think that's entirely true because you can see that there's a lot of other factors that might be playing a part in there. Would you say that it is um, counterproductive to try to convince them of something different, or is it beneficial to try to do that?
A great question. I don't think it's a hard and fast rule across people because it's going to depend on who they are and what your relationship is to some extent. And
Hmm.
so, um, I mean, there's some things that are better to leave sleeping dogs lie. I think that's reasonable. And also, I think sometimes it could be useful to just drop ideas that, well, some people have this and it's from, other things. And, just to maybe help them, uh, if the idea that they have is limiting them unnecessarily, I mean, I certainly would try to provide some education in some way.
Hmm.
But
Yeah.
if it's going to reduce, the quality of the therapeutic relationship, then, I'm going to have to judge the cost and benefit of that in the moment.
Yeah. Right. Yeah. And you have a new course that you've been recently doing on trauma care. So how does that tie in with your study with neuroscience and the other things that you're focusing on here?
Yeah, yeah, thanks for asking about that. So I offer this course on trauma-informed care, and it's really for any helping professional. But it was developed with massage therapists in mind because it's really a compression of everything that I used to do as director of the Pacific Center for Awareness and Bodywork. Um,
And
I'm
Mark,
not,
maybe can we backtrack for just a moment and
yeah,
talk a little bit about what is trauma-informed care? Because I know that's a
yeah,
term that
yeah.
gets bandied about a lot, and I'd like to
Mhm.
hear your take on that as well.
Yeah, it's really important to get clear on that because whenever I say it, I get a lot of different, it's clear that there are a lot of different ideas about what that means.
Hmm.
So you have trauma treatment on one hand, and you have trauma-informed care on another. So trauma treatment is what psychotherapists and counselors do with a license to do that. And trauma-informed care is something that any helping professional could be educated in. You're not actually treating trauma. So you're not going into the trauma, you're not trying to change people's patterns or, get into their psychological strategies or anything like that.
Can we go
Um,
one
s-
step further back even and say what we
sure.
mean by trauma?
Yeah, absolutely. Great. Very important to do that too. So a lot of times people think trauma is an event that occurred, but actually it's really what you take with you from that event because lots of people can experience the same event, and some
Hmm.
people walk away rather unscathed, and other people are impacted, so their functioning is impacted long term. And so trauma is that thing that is within us that prevents that normal functioning. And that could be shock trauma from like a singular event, like a violent event, or it could be developmental trauma. That's something that's occurred relationally in one's childhood, probably over a long period of time. So it really affects people's like social strategies. Uh, so that would be from developmental trauma. So either one of the, it's kind of unfortunate that we have the word trauma for these two very different things because the first one, shock trauma, is more an autonomic fight or flight, those kind of things, whereas the developmental trauma is more about structural psychological changes. It's not an autonomic kind of thing, although autonomic responses can be involved.
Hmm.
So trauma-informed care is about how can we respond, how can we work with people who have trauma in the most effective way possible, and it's kind of like we all take first aid and CPR classes, but we're not doctors.
Hmm.
Okay, so you want to be able to be prepared with something like a strong trauma response comes into play. That's a minimum requirement in my mind of a trauma-informed care of how do you respond to somebody. Let's say if they have a panic attack on the table, what are you going to do? Uh, or you could think of it as like being ADA compliant. We don't do hip surgeries, but we put wheelchair ramps in. So, you're working with people with trauma, but you're not treating it. You're just making sure that you know how to best accommodate individuals with it.
Hmm.
And it's so important.
Are there important examples short of a panic attack of how this might show up on people's tables, why they'd be interested in this?
Yeah, absolutely. I mean, especially with the developmental trauma. I mean, you're experiencing it all the time. People can't really say what they want in a session because they have a lot of trouble expressing, their needs. That's a really big deal because expressing needs and their past has not gone so well for them during their childhood, so they've learned to like not really have needs. And so if you ask them like, what do you need in this session? It's almost like I don't even know. That's one of many examples. Just expressing boundaries. Uh, there's all sorts of personality dynamics that are occurring between client and therapist that it would be really easy oftentimes to get annoyed at or um, not know how to respond to, or just to think, oh, this person is uh, annoying or weird, or I don't feel good around them, like, or to just judge them as like something is like wrong or bad about them. So a
Mhm.
trauma-informed approach is a non-pathologizing approach. It realizes that anything that people are doing that you might put under that like pathological or annoying quality, there's a reason for it. There's a function there, and so once one recognizes that, it becomes a lot easier to work with people and to actually provide better quality care for them.
These are, I think, crucially important skills that you're talking about here, and things that I think are pretty substantially missing from our training in a lot of respect. And I'm assuming that's probably one of the reasons why you're doing these things in your courses. So, are there any other, ways that you can encourage or suggest that practitioners sort of learn even some basic fundamental skills around the best kinds of things that they can do for that without getting too far in the weeds?
Hmm. Yeah, there's definitely levels that one could get into. And
Mhm.
um, uh, maybe before I answer that, I should just mention that I think for massage therapists, it's really much more important than it is for um, other professions. I mean, other professions, as long as there's people around, there's trauma.
Mhm.
As long as you're taking care of people or you're like in a room, like just alone with people, there could be, trauma. But we have touch added to the picture, and there's just so much to that. Um, and we think maybe touch is like the obvious thing is, oh, what if they've had, sexual traumas before? So touch, that's the easiest one to think about, but
Mhm.
there's so many more things that are relevant and counterintuitive, like even feeling good can be a issue for people. So, people come in, they get a massage, they feel great. You think, what could be wrong with feeling good? But, you look at the ACEs study for trauma where people were on this diet and all of a sudden they quit. And then they quit right before they succeeded in their diet. And it had a lot to do with not feeling worthy to actually complete and to, be successful. So there's a lot of things where you think, well, of course I want to feel good, but actually feeling good is a challenge if for individuals who have issues of self-worth. So you have to know that as a massage therapist, and as a massage director of a school too, that people are coming in, they're feeling good, and that actually is going to create some interesting psychological issues of where they could push back against you in various ways. And you got to be prepared for that because otherwise people are going to think, I mean, it could actually show up as pain the next
Mhm.
day, and we think, oh, they have pain the next day. Was it my elbow I put too much pressure on? But actually, it could be this psychologically driven trauma response. So, and now I'm forgetting what your original question was. I'm sorry.
Well, no, that's all right. We were kind of getting into the the kinds of skills or basic things that people could be aware of that would help them, just act a little bit more aware or prepared for some of these types of things that might encounter them. The reason I ask that is that spent a lot of years teaching entry level education and had a lot of therapists talk about the first time something happened in the treatment room where they were unprepared for the emotional response that came from the client of something that happened. And they just felt like they didn't really get prepared for what to do in those situations.
Yeah, yeah. Well, I mean, there's so much to this. I could talk all day. So. Well, one aspect, is we know what do you do when emotions arise, and that's um, there's many answers to that. I've heard of people who've gone to massage schools where they said, well, we were taught if someone starts crying, you should just leave the room and come back in 2 minutes. So that would be an example of what I wouldn't promote.
Yeah.
I think we can do a lot better than that.
Mhm.
Um, but on one level, there's this idea of acceptance. And so let's say somebody is crying because of grief. I think, yeah, we should be like certainly just be there in acceptance
Mhm.
to whatever extent one can be there. But on the other hand, if you have other responses that are not, I would call grief a primary emotion, and I would call other things you don't actually want to, like if you're having a panic attack, you don't want to take an acceptance uh, pr principle there. You actually
Mhm.
want to change that.
Yeah.
So learning when do I want to just sit and be with and allow and facilitate, and when do I want to help shift it? That's a skill
Mhm.
to develop with trauma. And I think one of the major ways we probably make mistakes as helpers is we have agendas a lot of times. We think, oh, this is what's going to help you, so I'm going to do this to you. And it's, as opposed to just listening with the body and really feeling what's the next right thing. So, I think many people have stumbled upon this idea that without being trauma informed, just like if we just learn to listen, we can do the next right thing. Um, as opposed to just coming in there with an idea of like, this is what you need. And that can be problematic for people who have been, haven't really had a voice or a say.
You're saying that listening can be the problem for people who have had a say, or not listening?
Oh no, if we're not really listening to
If we're
them.
not listening, okay.
Mhm.
Well, you're implying in some of your answers too that there's a step possible beyond listening. Listening is pretty inarguably great, and the
Mhm.
better we can be as listeners, the better we're going to work with. But you're talking about some discrimination too about how do I interact at that point? How do I let people know I'm listening, and what are the possibilities that opens up in that
Mhm.
moment?
Yeah, yeah. Mhm.
Different discussion, but that's great. That
Different.
sounds like you're working into that in your course, perhaps.
Yeah, there's in my course we work with skills about how to respond to individuals in those moments, and then we also do some learning that's like self experiential learning. So we're not just doing the concepts on the chalkboard, we're actually experiencing them. Uh, so especially around the ideas of whatever our strategies are, there's something useful to those strategies. And that relates to ideas around posture too, to the idea of like not thinking of posture as this bad thing, like whatever somebody is coming in as, that's actually a great adaptation. And we should stop telling people that there's something wrong with their posture because actually, neuroscientifically, if that's the posture they're in, that's actually the least nociceptive posture probably that they have found. So, which has a whole other topic I could talk about forever, but it's a similar principle though of like, we have just to stop pathologizing around all across the board, both physically and psychologically.
Yeah, I want
So,
to dig into the posture one at some point. That's great. I got some thoughts about it too. But Whitney, where would you like to take it?
well, I want to go down the posture road for just a moment as well, because I do think this is so pervasive and so relevant in our fields. Just for at least a little bit of rabbit hole on this one. Uh, Mark, what do you think is the sort of degree or relationship in which, like, when is that necessarily relevant? Because there are people who might come in that are doing something that we see, that we think that the repeated posture or the repeated movement pattern they're doing is a part of what's causing their nociceptive driven discomfort. Do we intervene, or are you saying that this is most of the time just something that's it's secondary and adaptive to what else that they're currently living with?
Yeah, well, clearly, if they have a job, like they're painting ceilings all day, I mean, that's a different. I don't really consider that really part of the posture discussion. That's more of a task-based
Hmm.
kind of thing. That person wouldn't choose to be in that position all day.
Yeah.
So I'm not sure if that's what you the kind of thing you're referring to, or if you just like, because there's a general thing of like, oh, your head's too forward or your shoulders are forward, which isn't really about a task. It's just about people's natural position.
Yeah.
That's more where I would what I would refer to as the posture discussion.
Yeah.
Yeah, so I wouldn't try to change anything. I don't care about people's posture at all. I think it can be useful to, as a starting point for exploring things, but I have no agenda whatsoever to suggest that they should be in one particular place or another unless they want to be.
Hmm.
It's not, it's their choice. They're interested in that.
So
Let's
do you
say
think
they
the
want to be.
body
Let's
is,
say the client comes in and they want to be in a different. Boy, my head's too far forward. I really don't want that.
Yeah. Well, I mean, I can't change that. I can't change their tissues. So
Mhm.
they're going to have to, figure out a way to change uh, their habits. But, people, when they try to change those habits, they often find that they get more pain because that they were already in the least nociceptive position. We do that in our sleep. We find our least nociceptive position. We do it all day long, subconsciously. So it's reasonable to assume that whatever position we're in is the least nociceptive. So if we try to find another one, it's probably a reason why we're not there. But there's so much more to it than the nociception. There's also these a whole bunch of psychological pieces too that if we really wanted to dive in, we could dive into as well. But some people have postures that are more psychologically based than other people, and if they wanted to change it, I'm not going to, first of all, I'm not going to change it, but even if I could, I'd be fighting a nervous system that's saying, hey, I'm doing this position because this is the position that made me feel safe as a child. So,
I like and
yeah.
agree with a lot of the way you're describing it. Posture that I'm in is the least nociceptive arrangement. There's something very Taoist about that, going with what is manifesting as the best possible outcome from all the different forces at work.
Mhm.
And uh, the part of me that is oriented toward possibility
Mhm.
says, is there a role I can have in opening up options for people?
Yeah.
Not to place them in the correct posture with the belief that that's going to make them pain free.
Mhm.
We're not, I think most of us are in agreement that's not a fruitful path.
Mhm.
But is there a way that resting position, habitual posture, is a an avenue toward more well-being or toward less pain?
Yeah, I think that's definitely worth exploring and looking into possibility for sure. Yeah.
and how
Yeah.
do you sort of recommend, I'm thinking of in terms of what the client themselves might express or what certain practitioners might express, how do you unwrap or unravel the perception of these two things being causal and not just correlated when somebody comes in and says like, oh, my neck hurts, and that person has forward head posture and slumped shoulders or whatever it is, the immediate jump to, well, that's why your neck hurts. What are the kind of strategies or other ways that people could look at that?
Yeah. Well, I mean, the immediate um, putting things together like that, I just think we should not do that because
You
it's
shouldn't assume that things hurt because the head's forward, you're saying.
Mm.
yeah, yeah. We shouldn't try to think that we can know these things in the
And
first
with
place.
just for fairness, I should bookmark there are entire disciplines and schools of thought that basically that's still the central paradigm.
Absolutely.
Yeah.
Yeah.
Right. Right. So I'm not sure about your audience here in terms of where they're at with that, but I encounter it all the time. So
Mhm.
um, it seems very important I mean, on Facebook groups all the time, people are saying things like that. So um, I think it's a very important thing to get away from. But if we're going to move the discussion forward with individuals who are kind of already on that, who get that that's not the case, how do you explore, other possibilities is to explore with them, uh, different positionings and movements and let them introspect on how that feels and what that's like for them, which is interoceptive, but is also psychological. A person could say, what's it like if when I bring your shoulder into this position? They say, well, I guess it feels okay, but I also feel nervous for some reason. Like, well, that would be, um, I mean, why is that, right? That's a whole thing to explore. And so, one of the, I just have to mention this that like if one of the we're all familiar with the fact that we get into certain postures to express certain feelings, but I think one of the things that we don't really realize is that certain postures that we get into actually block certain feelings, and try to stand at attention and also feel grief at the same time. You can't do it,
Mhm.
and there's a whole bunch of postures like that that you can't feel certain
I
emotions.
could do it. I can do
Yeah.
it. Sorry.
Okay. It's harder.
Extenuating circumstances. But yeah, your point's
Mm.
taken. It's
Yeah.
tough to feel different everything in every position. Yeah.
So someone comes in, and they're in this upright uh, position. Maybe it's, so they don't feel, never mind pain. How about emotional pain? So there's this whole other realm there that I think is much more nuanced and sophisticated realm that than just thinking about blocks being stacked on top of each other.
Yeah.
I mean, a little personal anecdote there. I'm really enjoying some Pilates instruction I'm getting. It is very much form based. It's very much about alignment as an externally applied template, which is not
Mhm.
my therapeutic model at all. And I've
Uh-huh.
spent a lot of time railing against that.
Hmm.
And yet, to have someone skillfully inviting me to move into places I didn't know I wasn't moving into
Hmm.
is opening up lots of possibility for me.
Yeah.
And there's like, oh wow, I didn't realize that I wasn't even doing that. And what
Uh-huh.
if I do that? And this is
Mhm.
pretty cool.
And there
Yeah,
may be something
absolutely.
to just novel movements
Mhm.
associated with that too, that give positive sensory experience from those novel movements.
Yeah.
So
Hmm.
many of the things we do, work because we're just riding on the coattails of all this, interoceptive goodness,
Hmm.
right? Whether we have good ideas about how they work or not, it's still good.
And
Yeah.
options are helpful. And like I don't even realize what options I'm not exercising sometimes.
Right.
Hmm.
Yeah. So,
Totally.
Mark, I know we've talked about some of these things, especially here recently. Any other uh, big myths or misconceptions you see out there about pain associated with the work that we do as manual therapists, massage therapists that you might want to help us dispel?
Yeah, well, I imagine that you've probably dispelled, before the same ones I would mention,
Mhm.
these posture ones and, a lot of the structural ideas, which again is, it's a nuanced conversation. Of course, there are structural and tissue-based phenomena. Um, it's just we need to get away from this idea that everything is that way. And it makes sense that we think that way because we grew up working with objects and manipulating
Mhm.
objects and understanding how objects work. So it's an easy thing to it's a metaphor that we first go to, but a lot simpler than understanding, neural networks.
And the big paradigm shift that happened around somatic arts emerging was that there's a physical aspect to a lot of these things we hadn't thought of as physical.
Mhm.
Right.
And so the
Hmm.
pendulum swings to like, okay, so everything's physical, and maybe we can affect everything through the physical means. Plus, I can feel a dent, a harder place in your body, and when I get it to soften up, you feel better. So
Hmm.
that's evidence then that we just need to make you soft, and you'll be great. Yeah,
Yeah.
I
Hmm.
just I got lost in that rabbit hole a little bit.
Mhm.
Yeah. I mean, it's complicated. I think, it's just a big dose of humility is really important for all of us to recognize that it's really hard to figure out what's actually going on.
Yeah.
Yeah,
And that there's a place beyond being agnostic about everything,
sure.
Mhm.
or just it depends as the answer to everything, or even nihilistic saying it doesn't really matter what we do or how we stand or how we are, for example. There are
Right.
ways to into experience that bring more of what the person or the car clients want, what they're more aligned with what they're motivating to seek their times with us.
Mhm.
Yeah.
And
Yeah.
your empirical, experiential based examples of helping someone find an experience and then checking with them and following their lead around their side of that and where that might be useful, what's in the way of that is a really interesting way forward.
We can do good work if we think we're changing tissues, even though we're not changing tissues, just because touch goes a long way and being a caring person goes a long way with the descending modulation and all that. But Um, if we know that we're not changing tissues, then maybe we don't have to work with that mindset and we can think interoceptively, like how can I change interoception without working so hard?
Yeah. But essentially, there is, in some instances, would you say that there is, I mean, what Till just said a moment ago in terms of an experience that we have of something was feeling dense and we worked it and it now feels less dense.
Hmm.
We have somehow or other facilitated that change of tissue quality, right?
Yeah,
Yes.
and the tissue,
Hmm.
I should
Yeah.
just say the tissue debate is not settled about
Yeah.
whether or not we're changing tissues and the clinical
Yeah.
significance of that.
Yeah.
It's a really great juxtaposition to think, what if everything was based on that idea and what if nothing was? But we're still not in agreement in our field about the role of the tissue change or our ability to
Yeah.
affect it. And there's good evidence on both sides.
Right.
Yeah, that's why it's important to be open and not too fixed.
Yeah. Indeed. Yeah.
To massage out those dense spots in our thinking.
Yeah. So, Mark, as a wrap up, if you could give us, or our listeners, one piece of advice to practitioners looking to kind of deepen their understanding of pain science, what would be the one thing that you'd tell them, go do this at least?
Um, to deepen on pain science?
Yeah. Or just their understanding of the role of like you've talked about the complexities of the whole neuroscience of pain process. What kind of would be really the most beneficial things for somebody to get started if they haven't really dived into this very much?
Yeah, I think it's really important to understand descending modulation. And I don't know if I mentioned this at the beginning that, descending modulation is just one type of top-down process, but all the other endocrine and immune changes that can occur, if you feel safe or, cared for, all those things we're not just doing descending modulation to the spinal cord, we're also influencing, a whole chemical soup in the body that could be relevant, which is probably why a lot of things change after massage for a few hours or days.
Hmm.
So, to really understand, like to dive into those explanations, these endocrine, immune, neuro understandings, and to see if you can replace those structural mindsets, with these. I think that would be where I would encourage one to go.
Great. That sounds good. Well, thank you so much, Mark. And is there any places that you want to encourage people to connect with you if they want to learn more about what you're doing with your courses and things like that? Where can people find out more from you?
Yeah, absolutely. They could go to my website, which is drolson.com, and that's dr hyphen Olson.
Hmm.
And yeah, that just you can see all the courses there. I've got courses on pain and trauma-informed care and other topics.
Okay. Excellent. Well, we want to thank you so much for taking some time out to chat with us today. This is absolutely fascinating discussion, and I think I did make note of at least quite a few other rabbit holes we probably want to try to dig down into sometime in the future as well. So,
I would love that.
yeah, great.
I appreciate
Uh,
the voice you're putting forth in our discussions too, and the place you hold and the perspective you have. Thanks for doing that all these years.
Yeah,
Yeah.
thank you too,
Yeah, please keep it
both of
up
you.
for us. Yeah, please keep it up. Yeah. And thank you all for being with us here today, where Books of Discovery has been a part of the massage therapy and bodywork world for over 25 years. And nearly 3,000 schools around the globe teach with their textbooks, e-textbooks, and digital resources. Books of Discovery likes to say that learning adventures start here, and they find that same spirit here on the Thinking Practitioner podcast, and are proud to support our work, knowing that we share the mission to bring the massage and bodywork community thought-provoking and enlivening content that advances our profession.
Instructors of manual therapy education programs can request complimentary copies of Books of Discovery's textbooks to review for use in their programs. Please reach out at booksofdiscovery.com. Listeners can explore their collection of learning resources for anatomy, pathology, kinesiology, physiology, ethics, and business mastery at booksofdiscovery.com, where listeners like you save 15% by entering thinking at checkout. And as mentioned, please let them know you heard about them here. That really does support this show.
And thanks to all of you, our listeners, and to our sponsors, you can stop by our sites for the video, show notes, transcripts, and any extras. You can find that over on my site at academyofclinicalmassage.com. Until where can they find that for you?
My site, advanced-trainings.com. And Whitney and I want to hear your ideas about what you'd like to be hearing here, or your input or your feedback, your questions for us or our guests. Send us a message or an email. Our email is info@thethinkingpractitioner.com, or look for us on social media. Just under our names, my name, Till Luchau. Whitney's, what's your name?
Today, my name is Whitney Lowe. People can find me on social under my name over there as well. And also be sure to check out the wealth of resources for rehabilitative massage on our YouTube channel, also under my name there. We'd really appreciate it if you would take some time out to leave us a review on Apple Podcasts, and know that it does help other people find the show. So you can hear us wherever you happen to listen for your podcast. Please do share the word. As always, tell a friend, and we will see you in the next episode.
Thanks for joining us today, Mark.
Yep. Thank you again,
Thank
Mark. It was
you.
grateful.